So the treatment paradigms are disease-modifying therapies, which we're going to get into, treatment of acute flare-ups of MS, which is also part of the standard of care, treatment of the symptoms of MS, the sort of things that Dr. Quayle just outlined, treatments that improve recovery from flare-ups, and treatments that improve function. And that's our current armamentarium, and it's a lot, and it'll impact how we have our discussions now moving forward. So from a payer perspective, we talked about this a little earlier, MS is a small percentage of the population in Dr. Fish's organization. But how's it hit your radar screen?
It definitely hits it, and as you said, I can tell you actually out of 250,000 lives that we cover, how many exact patients we have with MS, and it's a smaller amount, but because of both the economic and the social burden of it, it definitely is on our top 20, and in fact, it's probably in our top 10 diseases that we work on and manage the patients with because of both of those.
Now, can you estimate how much of that is cost of disease-modifying therapies versus cost of disability and chronic care?
You know, off the top of, we have that data, but we have not looked at that data for a simple reason. Right now, there's no reason to look at that data, but we could do it. But I will tell you one thing that I do know is that as the cost of the medications have increased dramatically since 2010, that the entire treatment cost, including everything that we've talked about, has gone up and up and up. And what I'm not even talking about right now is what the family of the patient themselves and anything that the managed care organization doesn't pay for it, because I'm certain there's a whole host of things. So, for example, you talked about patients who have bowel or bladder control. One of the things that a managed care organization doesn't pay for would be the special underpants to wear for it. That's actually not, that's going to be on the patient's burden themselves. So not only do we have a very large economic window there, but there's a lot of things that the patient themselves or the family has to cover also. So
and just time of caregiver costs.
Absolutely.
You know, we've taken a look on the in our employer groups, about 3 million members, so it's a substantial group. We've actually done a 3-year analysis of medical versus pharmacy MS cost. Now it's direct medical costs, so some of the things like things that plans don't pay for that Leslie mentioned aren't in this analysis, and the burden of chronic care, again, that a plan may not pay for if you're at a custodial level. Roughly 85% of the expenditure for MS is on the pharmaceutical side. Now that includes disease-modifying therapies and other treatments which can improve function and treat acute flare-ups. And only about 15% of the cost is direct medical costs, such as diagnostic evaluations, hospitalizations. That's actually shifted over the 3 years. It was about at 80-20 3 years ago. It's now 85-15, which is probably a reflection of increased cost of therapies.
So how about hospitalizations? Have either of you had any experience with tracking hospitalizations with MS, which, from my perspective, have gone down dramatically over 2 decades?
Yeah, we have, but it's really pre and post disease-modifying therapy. And really, MS didn't cost a health plan much prior to disease-modifying therapy. There were a few hospitalizations. They were relatively short and intermittent. These are not the patients that are in the hospital every month, like the congestive heart failure patients or the COPD and exacerbation. Fast forward to the era of disease-modifying therapy, we see almost no hospitalization, hence the reason why less than 15% of the cost is due to medical. It's mostly non-inpatient medical costs.
And I think what you still see, and the problem is, as Gary just said, is that there wasn't a lot of hospitalizations, again, in comparison to other diseases where you can see a lot more of hospitalization. I think the one area, though, Gary, that we may have also seen a decrease in is high-dose steroids that you may be using to treat acute attacks. However, they still use them. But again, it's not a full hospitalization. That's given in an outpatient or in an office. So.
Even at home?
Depending on the situation, that changed actually before disease-modifying therapies, the shift to more outpatient care for the acute flare-ups. But there's still some that get hospitalized. And correct me if I'm wrong here, Pat, but I think that just about every agent we have of the disease-modifying therapies has shown a decrease in the usage of need for steroids for acute relapses and in the hospitalizations for acute relapses. Is that not correct?
That's true.
And so that ought to be factored into the equation as well.
Well, it is factored into the equation, but when you are decreasing a low utilization, you can only take so much away. Again, if you're looking at, less than 15% of the cost is medical, even if you eliminate half of that, it's not a big number compared to the pharmaceutical costs. So, we really haven't enjoyed cost offsets. It's actually been a cost increasing area over the last 20 years.